Good afternoon, everybody. Welcome to the Cambridge Centre for Health Services Research 2025 annual lecture. It's lovely to be able to welcome you all today. I'm Jenny Newbold. I'm a founder member even, of the Cambridge Centre for Health Services Research, and I'm a senior research leader at RAND Europe. I'm joined today by the CCHSR co-director, Professor Stephen Morris, who's the RAND Professor of Health Services Research at the University of Cambridge. Steve will be chairing the discussion later in the session. And the CCHSR, as you may know, runs a programme of collaborative research between RAND Europe and the University of Cambridge with the aim to inform policy of health services research. We're absolutely delighted that Professor Martin Knapp is joining us today and is going to talk on the big shift from hospitals to communities. Welcome, Martin. Thank you so much for joining us today. And before I introduce Martin properly, just a few bits of housekeeping for today. We're going to be recording the session. Copies of the slides will be available on the CCHSR website after the session. You're able to ask any questions through the Q&A function through that button throughout the talk, so please do use that. A colleague will be monitoring those responses, and Martin's told me there'll be plenty of time for questions, so please do fill those in as the session goes through. Let me introduce Professor Martin Knapp. I'm sure his name will be known to many of you. Martin's a Professor of Health and Social Care Policy in the Department of Health Policy and Professorial Research Fellow in the Care Policy Evaluation Centre. Many of you will know his work, particularly on economics and the policy of long-term care and in the area of dementia care particularly. But he's worked on much more than that, and the breadth and depth of his 50 years of top quality research is truly remarkable. Already in the 80s, Martin was writing about the economics of care in the community, long before many others were. And as so often the case, the healthcare policy and the big shift of people of health coming outside of hospitals and into community is nothing new, but something that's become a really hot topic, particularly recently. But what have we learnt about it? Martin's really well placed to comment on that, and that's what he'll be doing in the session today. So over to you, Martin. Thank you very much.
Thank you very much, Jenny. All right, let me do the most nerve-wracking thing, which is sharing my slides. Okay. So hopefully that's visible to everyone. So thank you very much indeed for giving me the opportunity to give the lecture this year. I'm delighted, very delighted to be able to do that. So I'm going to draw on some work that we've been doing in my centre at LSE and some work that Jenny mentioned how old I am and how long I've been working in this area, but I can draw on some of the older work we've been doing. And let me just show you my structure for today. So very simple structure. So I'm going to say something about the focus, as you know, is the big shift, one of the big shifts in the NHS 10-year plan. I'm going to focus on initially the ambition, secondly, just describe the context or the landscape, thirdly, mention some challenges perhaps around feasibility of achieving that big shift. Fourthly, then going on to some of those operationalization challenges and perhaps responses to those challenges, and then finish with a very brief section on conclusions at the end. And I put a disclaimer in there. So some of the work I'm going to show is funded by the Economic and Social Research Council. Some is funded by the National Institute for Health and Care Research, but these are my views. I didn't add it on the slide, but I don't think I have any conflicts of interest which will interfere with what I'm going to say. So that's my plan. And that's the photo, by the way, is Lady Bower in mid-August this year. And that was a very beautiful walking day. Okay, so ambition, first of all. I'm just going to start with pre-government. So Labour Party in their manifesto set out these 5 missions for a better Britain. And you can see the second one on those is build an NHS fit for the future. And then that led to consultation, national consultation through the Labour Party, which helped to crystallise some of those mission aims, those ambitions. And that has led to what we're all very familiar with now, these 5 missions for government, kickstarting economic growth, an NHS fit for the future, safer streets, building opportunities, and something linked to clean energy, and all built on what they call strong foundations. So that's the sort of very broad context. In the health space, So Lord Darcy was asked to conduct an independent investigation very rapidly to take the temperature. What is the state of the health service? And I've just quoted one part from that. At the highest level, the NHS has had the strategic intention to shift spending from reactive care in hospitals to more proactive care in the community setting, but care has in fact moved in the other direction. And then what we saw, as in partly in response to that, of course, was the NHS 10-year plan. I'm going to show you some quotes from that and steal some of their infographics to illustrate some of those points I'm going to make. And particularly what the 10-year plan talked about were these three big shifts: moving care from hospitals to communities, making better use of technology, and focusing on preventing diseases. Now, the three of them are interconnected. I'm going to focus mainly on the first one, but of course that shift from hospital to community, or shift to the balance from hospital to community, will be supported considerably by making better use of technology, and certainly by focusing on doing more prevention. So these are interconnected. So why then was this shift being proposed? First of all, just a couple of quotes just from the 10-year plan to illustrate the challenge here. So the description of the 10-year plan of the health service was, it's hospital-centric, it's detached from communities, it's organised into multiple fragmented silos. And a second quote, so the plan, the ambition is to deliver this movement, this improvement in health service by increasing the share of NHS resources spent in the community and decreasing the share that is spent in hospital settings. And that's one of the lovely infographics we've got. Apologies for the artists there for stealing their infographics. But you can see that the plan then is to, in the bottom left, lots of emphasis on these neighbourhood health centres to be based in every community, providing lots of the things that would today be seen in hospital settings, bringing the NHS closer to people in their communities, modernising the hospitals that will remain. A new era is called for general practice, and creating community health teams to support people in their communities. So why this shift? If you go through the 10-year plan, a number of reasons come through. The first one is convenience. The aim is to put more and more staff concentrated, or more and more staff have been concentrated in hospitals, and the idea is now to embed a model of healthcare where you come to where the care comes to you rather than you come to the care. So shifting that expectation that people will have for how do they access their specialist services. Secondly, inequalities are mentioned quite a lot in the 10-year plan, and the argument is that they are exacerbated by the inconvenience of hospital services. I'm going to come back to that. I'm going to come back to all of these a bit later on. Thirdly, there's the argument about coordination, that currently healthcare is organised into multiple fragmented silos within the healthcare sector: community healthcare, primary care, mental health care, hospitals, and also fragmented across different sectors: social care, the rest of local government, the voluntary sector, and so on. If the NHS doesn't feel like a single coordinated patient-oriented service, that's for the simple reason that it isn't one. The fourth reason we hear in the 10-year plan is cost and effectiveness. And the quote I picked out here is, more care in the community is cheaper and more effective than care in hospitals. Fifth, there is mention about a crumbling estate, not giving a lot of attention in the 10-year plan, but noting that, as you can see there, care is disrupted in 13 hospitals each day as a result of crumbling buildings, crumbling physical capital. And this is an opportunity then to change the way that healthcare is delivered, whilst also paying attention to this crumbling physical environment. And innovation. So the neighbourhood health service, neighbourhood health centres will, it's said, become a hotbed for innovation. And if you search on the word innovation in the 10-year plan, it's mentioned 122 times. So innovation is clearly a major thrust within these plans. So that's the ambition. So what's the landscape And I just want to show you just a few things just to remind ourselves about what the current context is. So firstly, and I've copied, again, I've been outrageous in my copying of other people's infographics and summaries. This is from the King's Fund. On an average day in the NHS, you can read the slide, but 1.3 million people would see a GP. More than 300,000 will have an outpatient appointment. Nearly 35,000 will call for an ambulance. Nearly 46,000 will attend a major A&E department, and a third of those will be admitted into hospital as a result. And nearly 300,000 people will receive community healthcare. Now, interestingly, that number receiving community healthcare is smaller than the number attending outpatient appointments. But that's the scale of the sector that we know so well. And then a second bit of context would be public attitudes to the health service. Now, this comes from the British Social Attitude Survey, which Nat Sen have been running for 40 years or so, many years. And a report that was commissioned by the King's Fund and Nuffield Trust together. So what you can see there, I'm not going to go through each of the bullet points there, but what you can see is a very high level of dissatisfaction with the way the NHS is run, dissatisfaction with A&E waiting times, with GP waiting times, dissatisfaction with social care, and overall with the quality of the NHS. And the second bullet points out there that the dissatisfaction level with the NHS in 2024, which is the most recent survey for which we have published data, that level of dissatisfaction was the highest since the survey began in 1983. But at the same time, what the survey shows us, at the bottom of the slide there, is that there's still huge support for a universal, tax-funded, free at the point of use health service. So people like the overall model. There's no big push, no big suggestion that people want to change the overall strategic funding framework and delivery framework for the NHS. But there are many things that people find not very satisfactory in their access to services. So that's the context currently. At the same time, what we're seeing is a growth in needs, and the growth in needs is particularly driven by an aging population. But first, let me show you this one. So this is mental illness. So this is from a very helpful collation of data by the Health Foundation, 4 different surveys. Most of them are for England, but one is for the UK. And what you can see in those surveys over the period from 2010, or slightly earlier, 2008, through to 2022, what you can see is a growth in the percentage of people who report or have reported for them poor mental health. And this is a growth across all age groups, but especially in younger populations. So if you look at the red line in each of those 4 little graphics, the red line is for the youngest age group, the youngest adult age group in these surveys. And you can see a very, very marked increase in apparently prevalence of mental health problems. So that's not driven by the aging of the population, it's driven by something else. And the response to that, there are a number of reasons, a number of hypothesized reasons for this. Is it that the underlying prevalence is increasing? Is there actually just greater mental health literacy, greater awareness of mental illness? Are people more willing to seek assessment and treatment? Are mental health services more widely available? We've seen NHS talking therapies, used to be called IAPT, rolling out across the country. Are services easier to access? Are data recording systems better? Or is there overdiagnosis? And it's this last point which prompted, I think, the Secretary of State to ask Peter Fonagy to lead a group to see whether actually we are overdiagnosing mental health problems in our NHS. So that's one challenge on top of this huge scale and relatively low levels of satisfaction with the health service. And a second one relates to aging. Now, this slide comes from a paper in The Lancet 3 years ago, and it's the global prevalence. This is not UK specific, but the picture for the UK would be the same. So on the right-hand side, that's the overall prevalence number, the number of people, number of individuals with dementia, males in blue, females in pink, and you can see a very rapid increase over recent years and a very rapid projected increase And then on the left-hand side, this is age standardized. So there's still an increase, even though if you take out the aging of the population, there still seems to be an increase in prevalence. And that's driving, major challenges. Now I'll show you this next slide is from a piece of work that we did some years ago using older projections of the number of people with dementia. So what this shows you is the current costs in the left-hand column. Those are the costs of supporting people with dementia in England in 2015, based upon data we were able to pull together at that time. Actually, the colouring is not quite, but you can see the colouring is not quite right. The red, the key on the right-hand side suggests a different colour, but the red is healthcare, the yellow is social care, the blue is unpaid care, and there's a small other cost at the top. And then on the right-hand side, the right-hand column is what we projected on the basis of a previous bit of microsimulation modelling, what we projected the cost would be in 2040 if you don't change the system of support. So if it stays the same, then what you're going to see is a nearly 250% increase in overall costs of dementia, and the component elements of that, yes, a big increase in the cost for the health service, which will put further pressure on the NHS, but actually much bigger expected increases in social care and unpaid care costs. As I say, if we take today's system and don't change it, but continue to deliver services to people with dementia over that 25-year period. So major challenges that are expected. So then what's the feasibility? I want to look at the feasibility of shifting care from predominantly hospitals to predominantly community-based services. And I'm going to draw now on two things, particularly to begin with, a piece of work that we did very rapidly for the ESRC this summer. So back in May, I was approached to ask if we would do some rapid reviewing, and to which I said yes, and then was told that the proposal needed to be received within 2 weeks, which it was. And then we finished this in 15 weeks. And the little infographic on the right hand side shows you the front page of the cover, and it's got Sunday's date on because I'm going to finish it on Sunday. So we finished it in September. We're just taking account of reviewer comments, and we'll finish it this weekend, and we'll publish it hopefully next week or very soon afterwards. So what was the purpose of this very rapid piece of work? So we were asked to identify priority areas for research and innovation to support the government's health mission by shifting care from hospital to community settings. And we were asked to look at 4 clinical areas, and I'm going to say a little bit about some of them, not all of them: cardiometabolic conditions, dementia, mental health, and respiratory diseases. And what we did in this very rapid piece of work was to analyse, describe what we know about patterns of hospital use, that's inpatient, outpatient, A&E, a whole range of hospital services for those 4 conditions, to look at evidence on interventions which might shift care to the community. So we carried out rapid reviews, initially reviews of reviews, but then looking at individual studies. What do we know works in changing the balance from a hospital response to a community response to people's needs? For dementia, we used a different study that I've been involved in, which is mapping ongoing research. And then we consulted experts, about 17 or 18 people we spoke to, and that included some people who are experts by experience in those areas. So what did we find from that? First of all, just to say that kind of the conceptual framework is maybe a rather grand term for it, but the framework we used for this, so at the top you can see the 4 bullet points just indicate the activities. On the left-hand side, you can see the 4 conditions. And what we were interested in was interventions which would affect interventions for presentation in terms of people presenting with symptoms, for referral on to other services, for diagnostic investigation, for elective procedure, for recovery and rehabilitation. And what those might lead to then would be various what we called outputs, that is changing the pattern of engagement with services, so reducing admissions, reducing readmissions, reducing the length of stay, increasing the use of non-hospital services, and so on. We're interested in what those led to in terms of outcomes, and I've used the term outcomes very broadly here. So health, quality of life, impacts on families, communities, carers, impact on cost effectiveness, and then implementation. What happened then in terms of the evidence on what happens in the left-hand box changes the pattern of use of hospital services, changes health and economic outcomes, and what does it mean in terms of implementation challenges. And so the way we structured the work was then to identify, or to seek to identify, these three gaps. We call them innovation, readiness, and implementation. So an innovation gap is, in the way we identified it here, is where there are few or no interventions with demonstrated potential to shift the hospital community balance, where research needs to develop new approaches to find some of those solutions. So that's an innovation gap. A readiness gap is where interventions have shown the potential to shift the hospital community balance. That is, they're effective, but there is insufficient evidence to scale them up nationally. And then the implementation gap is where the intervention is ready to be scaled up, but this hasn't happened. So there are barriers to that implementation across the NHS nationally. So that's the framework. Now, those three types of gap, there's very blurred boundaries between them. So it's quite difficult to put things precisely into one box or the other. But this was the framework we thought was appropriate for the work we're doing. So I'm just going to show you just 2 or 3 results, not the whole set of results. As I say, we'll make the report available very soon once we've finalised it. So let's just look at cardiometabolic conditions. So in terms of what works from our review, these are interventions which appear to have evidence, strong enough evidence, robust enough evidence of reducing hospital admissions. So you can see 3 things there. The first one are for coronary heart or artery disease, coronary heart disease or heart failure. The second one is for diabetes, third one for heart failure. And these are all evidence-based and relevant to the UK. That doesn't mean the studies were conducted in the UK, but we think they are relevant to the UK context. This second box is for interventions that reduce hospital readmissions. And again, I'm not going to read through what's in the box, but you can see a range of different types of intervention: discharge planning, outpatient follow-up visits, specialist nurses for heart failure, for example, self-management for hypertensive disorder of pregnancy. So again, evidence that appear to be robust enough and recent enough and relevant enough in the UK context. Thirdly, reduced length of stay. Again, you can see some evidence there. When we were doing this, when I was not leading this team, as another colleague led this particular theme team. When the results came through, I was surprised by how little there was in terms of evidence, actually. And then overall, in terms of this area, the evidence gaps, innovation, few interventions for early diagnosis, for multiple conditions, for risk management, and lack of co-production of those services. In terms of readiness, limited evidence at this stage for virtual wards, for wearable technologies, for integrated care models. Implementation gap, unequal uptake of evidence-based therapies across the NHS, barriers in commissioning and post-discharge care. And then for each of these different areas, we identified some of the data challenges that we found. So that's an example from one of the conditions. Let me show you another one just quickly. So this is the mental health theme. And each of those, it's a very busy slide, a very big bold font, but each of those little boxes is showing you an intervention where the evidence is there, the evidence exists, and it seems to be robust enough that something can be done to change the use of hospital services, either divert people away from hospital, reduce the risk of readmission, get people out of hospital quicker, but some change in the use of hospital services. And in many of those cases, there's also cost effectiveness evidence, not just on the effectiveness, but also the economic implications. And then again, for the mental health area, but let's look at the evidence gaps just very quickly. So innovation, limited development of new interventions, particularly we found in relation to eating disorders, for example. Few studies on crisis care alternatives, on how to address self-harm. Surprisingly little research on good housing models in the UK, although there is some outside the UK, on how to support people with mental health problems back into employment and on digital interventions. I won't read the rest. I'll just show you the other themes here, the other gaps here. So what we're trying to do for this study is to find evidence on what does work, and then what does that seem to suggest in terms of evidence where, areas where the evidence is either completely lacking or is relatively sparse or poor in quality. And I have to say, the interviews we did with research experts in the different clinical theme areas were hugely important in helping us to identify these gaps. So let me then go on to operationalization and thinking then about, with the 10-year plan and its ambition, particularly to shift from a hospital-dominated system to a community-dominated system, what are going to be the challenges? What are the feasibilities and the challenges? Now, in starting off, what I want to do, first of all, is go back to what Jenny mentioned earlier, work that we were doing a very long time ago, looking at the closure of the long stay hospitals. Now, the context is different, and I'll explain how we need to be careful about the context. But I just want to look back then at some of the evidence from experience in closing the psychiatric asylums, long stay hospitals for people with learning disabilities, other long stay settings, and draw on some of the evidence there. Now, on the right-hand side of the slide, you can see a book that we wrote, which was when we were evaluating what was called the Care in the Community Initiative. If the book excites you, you can get it for £18.91 on Amazon at the moment. I checked at the weekend. And then in the bottom right hand of the slide, we did some work for the United Nations Rapporteur on persons with disabilities during COVID, when she asked us to look at the evidence to support deinstitutionalization at the time of COVID. So what we get from those studies in England and elsewhere are these, what I call mistakes is perhaps a strong word, but what went wrong in trying to close these hospitals and ensure good quality lives for the people who were living in these hospitals. And the reason I put these up here is because these same themes, these same challenges, I think are coming to mind, are being raised when thinking about operationalization of the 10-year plan. So one is in terms of funding. So there were areas. So I'll just point out on the right-hand side of the slide is a book edited by Julian Leff, which is describing care in the community, particularly the closure of psychiatric asylums, and drawing particularly on lessons in North Thames, in North London, with the closure of 2 hospitals. And I'll show you one more slide from that in a moment. And in North Thames, in that particular context, actually there was quite a successful move from a hospital setting to a community setting compared to many other parts of the country. And in North Thames at that time, there was good investment in capital funding upfront. There were double running costs. Resources were being committed for the long term rather than just short term. So funding models were generally okay in that particular context. There was a challenge in workforce. The workforce was resistant to change, and many people working in the long stay hospitals were not suitable for working in community services. There was a problem with siloed services, a lack of coordination across sectors. Families were not involved enough. Communities were often quite hesitant, is perhaps a polite word, for their views about moving people out of hospital. People living in hospital, the patients and residents, were rarely asked for their preferences in making the move. And transfers. So I'm going to come back to this. Transfers were often moved. People were moved in different types of people moved out of the hospitals at different times. And the consequence in many cases then were outcomes for some people were very bad indeed. So the lessons from that particular big policy shift, enormous policy shift, but in one particular area in relation to long stay hospitals, some of the lessons point us to things we need to think about when considering the 10-year plan. So I'm going to show you just some little graphics just to pick up on some of the experiences. Now, one of the hospitals that closed in this big shift was Friern Hospital in Barnet in North London. And I'm going to show you some of the cost findings from work that we did then. So at that time, when the hospital closure was first announced, the average cost per patient, per resident, per week was £595. That's a very old price level. So that was the average across the hospital. And in the first year, when the hospital closure started, a number of people moved out. I mean, overall, the hospital had about 1,400 residents at the time of announcement of closure. So a number of people moved out, and a year after they moved out, this is their cost in the community. So that's the first group of people to move out. In the second year, a different group of people moved out, and that's their cost 1 year after they left hospital. And I can just show you for subsequent cohorts of people as they moved out of hospital. So what happened was the hospital and the community services worked together, and it was the people who are going to use the word easier to move into the community who moved first, people with lesser needs generally. And then over time, the hospital gradually supported people with much more complex needs to move into what were more supportive, more expensive community settings. And overall, the average cost of community care 1 year after transfer was significantly higher than the cost of hospital. So I'm always skeptical when people suggest that community care is cheaper than hospital. I know we'd look at different contexts, but in this particular context, I think for what was generally speaking a successful program of support, this was not achieving a cost reduction. There's huge variance around these averages, so bear that in mind. But the overall picture was a successful program, I would say, in North London, but at higher cost. And now, with some embarrassment, I'm going to show you 2 slides which rely on my computer art, which are not particularly beautiful, but let me just show you these now. So this shows you what is the cost on the vertical axis and how does it vary with the severity of somebody's need. And that's the hospital cost and community cost. I'm going to assume that community is lower cost than hospital. That's the general assumption, but I could have changed the lines so that they cross at higher levels of need. Community might be more expensive. What we've got is in the community, that's the sort of average person in the community with this cost. Generally speaking, in hospitals, the average level of need is higher. People in hospitals have more needs for support and their costs are higher. And what we've often seen, unfortunately, is a comparison of these 2 crude costs, comparing the community average with the hospital average, but not comparing like with like. So the question is how much cheaper? And I think what often happens in these kind of comparisons, and there's a danger of this, that we compare the 2 different groups of people with different needs, and it's not obvious that community care really is that much cheaper. And the second thing that happens is we think about this transfer of people, this changing balance from a hospital-dominated system to a community-dominated system. If we look back to what happened with the closure of those old asylums, what usually happened was the sort of people who moved out of hospital and into the community were in that range between those 2 averages. So they were more in need, they needed more support than what was typically being seen in the community at the time. But they were also, in the initial years at least, the people who were perhaps less dependent, had fewer needs compared to the hospital average. And so what happened when that shift, when somebody with those needs moved out of hospital into the community, what happens is that the average cost in both of those settings goes up. And as I used to say when I used to present this work many years ago, this is what sometimes is called the migrating Scotsman phenomenon. The Scots would say that every time a Scotsman moves from Scotland to England, the average intelligence of both nations goes up. And what we got here is the average cost is going up in both settings, even though the overall cost of running the system will be reduced. So the average costs go up in both settings, and that can sometimes send confusing signals, if you like, to people managing the overall system. The other thing just to say from this old experience, many, many years ago, when these asylums were being closed, the assumption was that the land on which these hospitals were based would be released for highly productive use. And in fact, when we did a study many years ago now, looking at hospitals at least 10 years after closure plans were announced, half the land was vacant. So again, thinking about the repurposing of hospital sites, which is being proposed in the 10-year plan, it is really important that that opportunity is taken up. So go back to this is my slide I showed you before. I'm just going to show you a quote from a Lancet Commission on Global Mental Health, published a few years ago now, which is generally positive. I mean, I think what I don't agree with in this quote is that community-based models of care are necessarily cheaper than hospitals. But generally speaking, if you do it well, this can be a successful transfer. And it's then taking that history, I think, into today's context, today's challenges. So let's come back then to the 10-year plan, which often called, this shift from hospital to community is often called a left shift. So I think the 10-year plan, I think there are these 6 areas of challenges, which I'm going to talk through quite briefly. These are being raised by people commenting on the ambition in the 10-year plan. So firstly, in terms of service and treatment models, we have this focus, as I've said earlier, on neighbourhood health centres. But the big question about what do these services mean? What will they deliver, in fact? What will the new rebalanced NHS look like? It's not just going to be some new centre, it's what's in that centre. And the ambition is clearly not merely to lift and shift, take hospital services and plonk them in the community, but it is to reduce need and improve health. So it's changing the health picture as well as the healthcare picture. But we've got a whole range of models. The proposed actions mentioned in the 10-year plan are things like this: same-day emergency care, virtual wards, urgent community response services. There are others mentioned as well. But what we found in our review, funded by ESRC, is many innovation gaps. For many conditions, we only looked at 4 areas, 4 big areas, but 4 areas. But for many conditions, we still don't have a very good idea about what works in achieving a change in the balance between a hospital-based and a community-based service. So more research is needed in those areas. And that links to this next slide. So the Wellcome Trust, pre-publication, before publication of the 10-year plan, suggested there's a need for a 4th shift, a shift from research to reality. And in the interest of time, I'm not going to read through what's on the slide. The slides will be available afterwards. But this was saying that in order to achieve those 3 other shifts, hospital to community, analog to digital, cure to prevention, in order to achieve those shifts, we also need to invest much more in research and putting research at the heart of health and healthcare. As a researcher, I certainly couldn't disagree with that. So second challenge, second set of challenges relates to costs and funding. I just want to pick up on some of the issues there. So again, picking up from what people are saying in their commenting on the 10-year plan, what has been found in previous experience, it's clearly imperative to have good capital investment up front and double running costs for some years. You can't run down one system and build up a new system instantaneously. So it needs investment over a period. But the challenge is, of course, the NHS is in considerable deficit. So this is not an easy thing to achieve. Secondly, there's a need for multi-year financial and service planning. It's that predictability, that sustainability is imperative here, but that's always challenging given the political sensitivity of NHS performance indicators and so on. Thirdly, if there are savings, or certainly when there are cash releases or funding releases, they will be slow, and there's always a problem that decision makers may not be patient enough. So real urgent problems that emerge, a new pandemic or whatever it may be, is that going to take priority over the longer term ambitions? We need to make sure not to underestimate the resources needed to achieve effectiveness. So the points I made earlier about comparing like with like. And remember that hospitals have a huge economies of scale. That's why we like big hospitals, one of the reasons we like them. And that will be hard to replicate in smaller community settings. The evidence base is limited. That's what I mentioned previously. And then there's this issue here, what I call worth it. Health economists in this area will talk about, something being worth it. The cost per QALY is below the NICE threshold. It looks like it's cost effective by reference to standard criteria, but it still may be unaffordable. So getting some of these evidence-based interventions into delivery mode, into implementation, full implementation, is not going to be straightforward. But what we do see in the 10-year plan, and I think this is an impressive part of the 10-year plan, is a discussion of new payment models, the recognition that we need to change the economic incentives in order to achieve some of these changes. And I'm not going to go through what's on the slide there, but this is an infographic from the 10-year plan setting out some of the suggestions for changing the payment model. So another challenge is in relation to workforce, and it's again the 10-year plan has got a whole chapter on workforce, thinking about what needs to be done. And this is a quote on the left-hand side from a report from the King's Fund in 2024, so before the 10-year plan, talking about the need to increase generalism and multidisciplinary team working, and to change the training emphasis away from hospital-focused services towards primary and community-based services, stating the obvious, perhaps, but clearly not an easy thing to achieve. A fourth set of challenges then relates to sectors and systems. The NHS sits in the middle of a very complicated set of interconnections and systems, and what we need, community care, community-based care needs coordination across multiple sectors, and it therefore has to overcome the familiar challenges of silos, silo budgets, silo performance measures, and so on. But the challenge there will be that other sectors, and especially social care, have their own huge problems at the moment of underfunding and over demand, if you like. And that then needs, as people have commented in their reflections on the 10-year plan, aligned budgets, shared incentives, joint commissioning, and altered power balances. But of course, as we all know, history is not littered with great success stories in relation to those needs. And then finally, families, communities, and inequalities. And here's a question about messaging. So we know that if a suggestion has been made in the past to close a hospital, there's huge community opposition. People don't like hospitals closing because they associate hospitals with they're the places where specialists are based. So there's a need to get the messaging right about the 10-year plan. People associate community with primary care, but then reflect how difficult it is to get a GP appointment. Or they associate community with social care, and that's still sometimes associated with somehow failing to be able to live independently on your own. So the messaging is really important here. And then there's a question of responsibilities. Is this shift from hospital to community also going to mean a shift from formal services onto families, onto unpaid carers? What's going to be the implications for them of this shift? And in relation to inequalities, so the 10-year plan is quite clear. It wants to tackle inequalities which are clearly evident in today's healthcare system. It recognises that costs are often highest and outcomes are often worst for people living in disadvantaged communities. And those are the people who very often have the poorest access to evidence-based care. But as many people who've commented on the 10-year plan have said, reducing inequalities won't happen automatically. It needs concerted action within the implementation of the plan to make sure that happens. So to conclude, I've just got 2 slides to finish off in my conclusion. So firstly, to go back to the ESRC study that we've just finished or about to finish at the weekend, what about the evidence gaps? Let me just pick up across those 4 clinical theme areas what we drew out of our study. So the innovation gap, weak real-world evidence and UK-specific evaluations. Yes, of course, there is evidence and there's a really good evidence base, but it's still relatively sparse compared to the ambition within the 10-year plan across all the different conditions that we're thinking about. There's limited evidence, particularly evidence when people have co-occurring conditions. We don't see a lot of evidence to help to decide to shape what needs to be done. Limited evidence for people at the highest risk of some conditions and evidence in relation to marginalised populations. So the readiness gap, so how easy is it to move from perhaps pilot studies in specialist settings to more generalised contexts? There are inequities in access and readiness across populations. There's an unprepared workforce, insufficient evaluation going beyond pilots or controlled settings, limited evidence on the interactions across the system, and data systems are still not what we really need to help to translate evidence from those studies into a ready health system. And implementation, again, similar issues. There's tremendous unevenness in adoption and inconsistent delivery. Those are often associated with inequalities or inequities, and again, challenges with data sharing to help to smooth the system. And then we also drew some conclusions about data evidence, the availability of data, which I'm not going to go through now. So finally, then, let me go back to what I said. I would focus on these 5 areas. I'm just going to give you my very, very brief summary. So the ambition in the 10-year plan is enormous and I think appropriate. The landscape is complex already. I've said it's a complex system and it'll get more complex and more challenging because of the growth in needs that we are confidently predicting over the coming decades. In terms of feasibility, from our recent review, we think it's patchily evidenced, so a limited amount of evidence in this area, in some areas. Operationalization, multidimensionally challenging. I know challenging is a very overused word, but there are many areas that people have highlighted. The 10-year plan does not shy away from them. The 10-year plan addresses and talks about these challenges, I think very impressively, but these are nevertheless major challenges across many different dimensions. And as I say, the multidimensional planning, I think, I'm not sure I read every single word in the 10-year plan, but I read bits of every page. And I think it's a very impressive document, but this is a huge set of challenges that we are now facing. And with that, I will say thank you and finish. And stop sharing, I hope. Yep.
Martin, thanks very much. That was excellent and very thought-provoking and interesting. So my name's Steve Morris, and I'm RAND Professor of Health Services Research and one of the co-directors of the CCHSR. So thank you, everyone, for putting your comments on Martin's talk in the Q&A. Martin, if it's okay, we'll not let you have a rest just now. We'll quiz you a little bit more. So there's a lot of interesting questions coming up. A few people have asked about the appropriateness of the shift to the left, and that there might be a number of people and conditions where it's not really an appropriate thing to aim for. And so how do we judge that? So, for example, one anonymous attendee talks about how the fact that there's a whole load of people who can't be discharged into the community, and Anne Swift again thinks about that there are some hospital-based services where there isn't really much scope for the shift. So I just wondered if you had any thoughts about that and maybe the scale of that that kind of issue, please.
Yeah, that's a really good point. I think the shorthand description of the shift is we're going to change from hospital to community. The reality in the plan and all the discussion is we're just going to shift the balance. We're going to change that balance. We're not getting rid of hospitals. Or the plan is not to get rid of hospitals. The plan is to shift that balance. And I absolutely agree that there will need to continue to be services where you've got people with multiple co-occurring conditions, for example, or very complex needs where having all those different specialist departments in a hospital immediately at hand is going to be so important. And although we need to be careful not to draw too many lessons from the past, but I go back to the slide I showed you of Free in Hospital in Barnet, that in the last 2 years of the hospital closure, the people who moved from Free in Hospital did not move into supported housing into the community. Some did, but mostly they moved into quite highly staffed settings. One of them was a new facility built on the site of Free in Hospital. So they continued to live in hospital-like settings, even if they weren't called hospitals. And so I think that's going to be absolutely the case. So I can't see this changing. I think the challenge, the overused word again, but I think the opportunity now is to think about what can we gain from the evidence that's coming through from new interventions, the opportunities that are presented by digital approaches, the opportunities presented by better preventive strategies. Are there groups of people that we might today think could only be appropriately treated in a hospital setting? In the future, that may not be the case. So I think and I think the 10-year plan is open to that sort of investigation, that sort of ambition.
That's useful, thanks. So then a couple of people have asked about kind of prevention and public health. So Julieta Camino asks, what's the role of prevention approaches to both community and hospital costs? And then George Roberts said 10-year plan is very light on mentioning public health. What do you think the role of public health specialists might be in facilitating the left shift that you mentioned?
Yeah, two or three things. One, for sure, as I said in the presentation, the three shifts are interconnected, very, very complicated ways, and hopefully become even more interconnected over time. So I think it is important not just to think about this as shifting treatment or cure, but actually shifting the whole system, and that means putting more emphasis on prevention. So better prevention, more emphasis on successful prevention is clearly going to make it easier to shift that balance between hospital and community. Fewer people going into hospital or needing hospital type services, and fewer people when they arrive in a hospital type service perhaps needing complex or long stays. So that's important. I agree that public health is not given a huge amount of attention in the 10-year plan. I do a lot of my research in the social care area. I think social care is similarly not covered very much in that area. We've seen some of the commentaries we've seen on the 10-year plan from people in the public health space, in the social care space, would be maybe wanting to see more attention or more post 10-year plan publication discussion about the interconnections with public health and social care. So I absolutely agree. And I think, again, that public health emphasis then also reminds us of the complications of silos, given the situation of public health services within local government, given the, if I go back to the mental health area, most of the successful preventive strategies in mental health don't happen in the health sector. They happen in education settings, in workplaces, in communities, and so on. So prevention outside the healthcare sector is absolutely essential.
Thanks, Martin. And then I guess following that theme, we've had a couple of questions about impacts on other sectors. So, for example, Shabana Nagraj asks about the potential impact on the voluntary sector and charities, whether you've got any thoughts about that. And then Andrew Fairbairn raises the very real point about impact on GP services and primary care. So, for example, what might the impact of shifting from where possible from hospitals to community, what the impact might have there? Big questions, I know, but I don't know if you've got any thoughts.
Well, on the primary care one, first of all, I mean, I think, and I do a lot of work in the dementia area. We've been looking in a couple of studies led by one by Louise Robinson in Newcastle, looking at what's the potential for nurse specialists or other specialists based in primary care to support people with dementia and their families, and the potential is huge, but we don't see it being delivered very much across the country. So I think it's then changing the notion of primary care to make it more specialised in lots of ways. When I had my cataracts done a few years ago, it was in a primary care clinic. I mean, it was, I was very surprised when I got the address to turn up for that. So what primary care is doing and what can be done in primary care settings is quite important. I think in relation to the voluntary sector, yes, I mean, we do see quite a bit of mention of the third sector, voluntary sector charities in the 10-year plan. I think where it's going to be really important is perhaps some of those voluntary organisations which are a little bit below the radar. They're sort of community groups that might support people from particular cultural groups or ethnic minority groups, to help them to understand their health issues, to help them, to support them to be engaged with specialist services where there may be a reluctance or a lack of awareness of what's available. I think that's where it's going to be very important, because those are groups in the population that already have poor access to good quality healthcare services, and we mustn't make that worse by moving to a neighbourhood system which doesn't engage with those communities. So that's where charities, I think, are going to be hugely important.
Thank you very much. So MJ Long asks a question about virtual wards, which obviously we've heard quite a lot. That seems to be a bit of an emerging initiative, and there are lots of these initiatives starting up nationally. So the question is, what advice do you have for collecting data and outcomes so that different services can be compared and helping us to understand what works?
Okay, I'm glad the question is not about virtual wards, because I don't know very much. I know a little bit about them and not enough about them to comment. But I mean, more generally, in terms of that, I mean, I think one of the things I would say, and it comes through other things I've been concerned about for a while, but it comes through with commentaries on the 10-year plan and some of the evidence, is that I think quite often the evidence that is collected in research studies or used in policy discussions is a little bit too narrow in thinking about both outcomes and costs. So we tend to think about, and research tends to focus on, outcomes for people with particular conditions and doesn't think about the outcomes for the family members that support them. On the economics, on the cost side, I think quite often, most economic evaluations in the UK would focus on the health and social care perspective that NICE is interested in, but don't look at perhaps the employment impacts for patients, for carers, or think about the impacts on welfare benefits or other sectors. So I think in evaluating some of the options that might help to shift this balance from hospital to community, we really do need to make sure that research evidence is broadly, it's got a broad perspective. It picks up on the outcomes for all different groups and the costs across all different sectors.
Okay, thanks very much. Thanks, Martin. So Duncan Edwards has raised a question which a few people have thumbed up, which is about that there's sort of limited evidence, as you've cited, for the various improvements in community care. So why is there not investment in focusing on what we know works already, for example, in terms of general practice, district nursing, health visiting, community social care? And then Anne Swift adds to that, so innovation is fine. Older systems of continuity in community care seem to work rather well. So why isn't it a question? Why innovate? Why not just focus on what we do already and improving access to that?
I think that's a really good point, and that's why in the ESRC funded work we did, we started off with looking at what is the evidence base in terms of what we call the innovation gap, but then particularly thinking about what the consequences what the needs are to help to implement those things that we know work well across the country. So an area I know quite well in terms of research is the mental health field. We've had early intervention psychosis teams known about for a long time, with evaluations from 25 years ago showing how successful they were, but we still don't see that where they are now pretty much across the whole country. But it took a long time for those to be rolled out across the country. So I think it is learning from things we do know work. Although I said the 10-year plan mentions innovation 122 times, we don't always need innovation, but we do need to find ways, maybe innovating to help to understand how to overcome the implementation barriers. So maybe that's what's important.
Thank you. And this is the last question. I'm sorry, everyone, we're not going to have time to go to all of the questions in the Q&A, but just a question from Peter West about, can we afford local care and community care? So no queues, good staffing, but do you think the shift is actually affordable? And you present some very interesting kind of figures about that.
I always get criticised for being an optimist, but I am optimistic that I think the shift would help. I think people, I think there is, as the previous question suggested, there's lots of things we know do work, and we need to make sure we put those into practice whilst leaving ourselves open to new learning, particularly with digital interventions and more emphasis on prevention. So yes, it will be challenging. It's not going to be changing to phoning your GP and getting an appointment within 2 hours. That's not going to happen, but hopefully things will improve.
Thank you. Well, I think it's perfect to end on an optimistic note. I really like that. So thank you, everyone. We need to draw things to a close there. Martin, I don't know if you have any final words you'd like to share with us before.
Just thank you for listening, and I put my email address at the end. I'd be delighted to hear from people if they've got some follow-up comments and follow-up suggestions. That's what I'm keen to hear. So.
Thank you very much, Professor Martin Knapp, for an excellent and thought-provoking talk this afternoon. Have a lovely rest of the day, everybody, and see you all next time. Thank you. Thanks all. Cheerio.